Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA Primary Exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello everyone, this is James at GasGasGas. Today we are covering Suxamethonium, aka Sux, a speedy onset depolarising muscle relaxant, and the only depolarising one really. It seems to have a bad reputation. Some people call it a mean and awful terrible drug. I'm quite sure that every time it's used, a panda spontaneously expires somewhere in the world. Generally speaking, it is used less and less as the familiarity of rocuronium continues to climb, and probably further enabled by the presence and existence of Suxamethonium, enabling that rapid reversal of an RSI dose that probably means rock has the edge. Now, I've never ended up giving the 16 milligram per kilo emergency Suxamethonium dose, but if it works anything like as quickly as when you're reversing someone with one or two twitches only, upsa-daisy, then you're probably going to have a quicker return of muscle power compared to waiting for the Suxamethonium to wear off. Side note, if you think you're in a situation where you're going to be giving that reversal, just count how many ampules you think you're going to need to give, because then someone could just draw up and give, draw up and give, draw up and give, draw up and give. Or you pre-draw it up if it looks like it's an absolute disaster. Anyway, reversing their paralysis won't help if they're halfway between anaesthetised and awake, and therefore apneic or refusing to breathe or clenching. So anyway, now that we've waffled about that, we're going to focus on Sux. So, Doctor, what depolarising muscle relaxant are you aware of, and how does it work? The chief drug that comes to mind here is Suxamethonium. Suxamethonium has an agonistic action at the nicotinic acetylcholine receptor that is located in and around the neuromuscular junction. It binds to this receptor, triggers it into an open state, and then holds it in the open state until the drug wears off. You could describe this drug as two acetylcholine molecules bound together with a succinic acid. Of note, it causes a disordered contraction of all skeletal muscle at its onset, as it subverts the normal motor unit mediated muscle contraction, hence why you get the fasciculations. Suxamethonium itself binds to the alpha subunits of the nicotinic acetylcholine receptor proteins. Excellent. And how is Suxamethonium metabolized? Suxamethonium is broken down by plasma or pseudo cholinesterases. These are not present in the neuromuscular junction, unlike acetylcholinesterase. This means that once given IV, Suxamethonium begins to be broken down. About 20% of the dose of Suxamethonium will make it to the neuromuscular junction, and it diffuses into this space and has its action. It will not be further broken down until it diffuses out of this space, back down its concentration gradient as the plasma is cleared of any existing Suxamethonium from that bolus dose. Succinylcholine, Sux, is initially broken down into succinyl monocholine and a choline molecule, and then the plasma cholinesterases again break that down from succinyl monocholine to succinic acid and a choline molecule. Of note, the succinyl monocholine has weak activity from a paralysis perspective, but also acts on muscarinic cholinergic receptors, causing the bradycardia that's sometimes noted with Suxamethonium use. An extra dose of Sux would much more significantly cause the bradycardia. So that might be a classic opener to a question in a Viva. The important points there are the metabolism, the mechanism, and demonstrating an understanding of some of the side effects. Now I'm going to talk through the data for Suxamethonium, and then we're going to focus quite heavily on the side effect profile, which is another pretty neat question to ask in a Viva. Something along the lines of, Doctor, talk me through the side effect profile of Suxamethonium, and then you go on to say some things, and then they drill you down on the mechanisms by which those side effects come about. We'll get there in a second. So Suxamethonium is a depolarising muscle relaxant. Its chemical name, succinylcholine, reflects the fact that it's two choline molecules bound together with a succinic acid. It is a clear, colourless liquid that is stored at 4 degrees Celsius to preserve its effect. But of note, it can stay out of cold storage for a period of time and remain functional at least a week. It is an IV preparation in 50 milligrams per ml, classically with 100 milligrams in an ampule. Its routes include intravenous, intramuscular, or intralingual, the latter two being for emergent use. Its dose range is 1 to 2 milligrams per kilo IV and RSI, 2 to 4 milligrams per kilo IM, and in laryngospastic emergencies, 0.1 to 0.5 milligrams per kilo IV is sufficient to break the laryngospasm. From a pharmacodynamics perspective, it binds to the nicotinic receptor, which is found on the end plate of the neuromuscular junction on the muscle side. This triggers an action potential on that muscle, causing depolarization. The IV onset time is 30 seconds or so, and its clinical endpoint would be cessation of fasciculations, if you've seen them. It lasts 3 to 5 minutes. Its side effect profile, from a cardiovascular perspective, is quite stable. It may cause bradycardia with 1 dose, and it certainly has a chance of causing bradycardia with 2 doses. The odds of bradycardia are higher when given to children. From a respiratory perspective, well, it's naturally going to cause apnea once the patient is paralysed, but it has been known to trigger bronchospasm also. GI-wise, it increases intragastric pressure and can cause some salivation. Thinking about your brain or your eyes, it raises intraocular pressure and raises intracranial pressure. Its MSK effects include myalgia afterwards, borne out by the fasciculations generally, more common in women. It can cause a prolonged paralysis situation, this is called Suxapnea, and sometimes you can note masseter with administration of Suxamethonium. It also has a number of metabolic side effects. It can cause a transient increase in serum potassium levels and a lethal serum potassium level increase in those with poorly innervated skeletal muscle and those who are post-burns. It can also trigger malignant hypothermia and is prone to triggering anaphylaxis also. From a kinetics perspective, it rapidly is metabolized by plasma cholinesterases, meaning that only 20% of the drug dose gets to the muscle. Its pKa is not clear, its volume of distribution is not clear, and its protein binding is not terribly clear either, so I wouldn't really talk about that in too much detail in your exam. We've mentioned metabolism up there, however, go through it again. Suxamethonium is metabolized by plasma cholinesterases. This enzyme hydrolyzes it into succinyl monocholine and a choline molecule. The succinyl monocholine has activity. It seems to like muscarinic cholinergic receptors too, and can cause some muscle depolarization itself. The succinyl monocholine is subsequently broken down again into just a succinic acid and a choline. About 2 to 10% is excreted unchanged by your kidneys. This is an important point for later. Its half-life is 2.7 to 4.6 minutes. Now you could caveat that it's quite difficult to measure the protein binding and volume of distribution of a drug that is rapidly cleared in plasma, because as soon as you take that blood sample and trot it off to the lab, those enzymes are still quite busy in there. It is another drug that doesn't mix with thiopentone, even though you have a classic thiosux RSI. And it's important to note that some patient groups and some drugs modify the response to the sux. So there's a group of people who have a less plasma cholinesterase, and therefore the paralysis lasts longer. This is pregnant people, those with liver disease, renal failure, and thyrotoxicosis and subcancers. And a number of drugs potentiate the effect of sux, chiefly lidocaine, lithium, magnesium, apparently ketamine, and the oral contraceptive pill. You may hear or come across people describing pre-curarization This is where you give someone who's awake and talking to you a sub-paralyzing dose of non-depolarising muscle relaxant. Say you might give them some atracurium once the suck starts wearing off to keep them relatively still. You give that before in a small dose. They get few to no fasciculations and their myalgia is theoretically less bad. Boom. So now we find ourselves in the part of the podcast where we define or die. So if ever you're asked a question in the exam about a thing, pile in with one or two sentences that demonstrate that you know what you're on about regards that thing before going into that deep dive about how that thing works. So, side effects of Suxamethonium. We mentioned high serum potassium issues. What's going on there? It seems to affect people with poorly innervated skeletal muscle or those with burns for some unbeknownst reason. But what's happening on a cellular level is the proliferation of the fetal subtype of the nicotinic acetylcholine receptor. These spread out across the whole muscle as opposed to being located just in the neuromuscular junction. And then you can imagine that if you give a dose of Suxamethonium and it's now able to tickle 10 times or 100 times or 1,000 times, who knows how many times, more receptors, you're going to get a significantly greater response. Now, you can only depolarize muscle once, but all that muscle is a lovely home to potassium. Because remember, this channel lets sodium and calcium in and potassium out of the myocyte, and this can lead to a lethally high potassium, and they die on the end of your syringe. That's why people with burns from 24 hours onwards to 18 months, those who are paraplegic, tetraplegic, those with neuromuscular diseases where there's poor skeletal innervation, or paraplegics, all have trouble with this, so you would just avoid it. This issue is going to become less and less because rock uranium is just exceedingly prevalent in this. You can have a look on the show notes for that diagram that sort of elaborates on the difference between an adult and a fetal nicotinic acetylcholine receptor. Drew a lovely diagram for you, I did. So then another issue with Sux is triggering malignant hypothermia. So this is an autosomal dominant condition with runaway muscle metabolism secondary to contractile activity within the myocyte. The ryanodine receptor on sarcoplasmic reticulum in those myocytes is the implicated offender that is altered in this autosomal dominant problem. Hence it runs in families. What do you get when MH is happening? You get a sudden, large rise in carbon dioxide and a tachycardia. The patient then might go on to start getting very hot. Later problems include myoglobinemia and hyperkalemia and subsequent renal failure if that myoglobin bungs up renal tubules. It is generally bad, but certainly survivable with declaration of the emergency, seeking help, 100% oxygen, hyperventilation, removing the cause, sucks, it's already in, damn, or volatile, turn that volatile off, start some Tiva, dantrolene, and active cooling. So you need to not let them get hot because it's the heat that denatures the enzymes that gooses the person. If you can keep them cool, then you've got time to try and achieve everything else, achieve that quiescence of muscle, and it'll all be all right. Take a look at the Quick Reference Handbook. And don't forget to send them for testing and refer them to clinical genetics. Another of the joyous side effects of Suxamethonium, great drug, really safe drug, definitely would get licensed today, is Suxapnea, aka pseudocholinesterase deficiency. This enzyme is coded for on chromosome 3, and there are 4 varieties that may come about. So everyone has 2 copies of this gene. Most people are walking around with 2 normal copies of this gene. That is 96% of the population, and they're offset for Suxamethonium as normal. Almost the rest of the people in the population wandering around have 1 normal and 1 abnormal allele. Their offset time is only marginally prolonged because they've got quite a lot of decent plasma cholinesterase, 10 minutes for it to wear off. You've then got a group who are called the atypical group, and that is 3 in 10,000 people and the wear-off time is hours. You've got a silent group, as 1 in 100,000 people, wear off in hours, and a fluoride-resistant group, 3 in 1 million, wear-off time, hours. So you can say that most people are fine. Almost 4% of people might just have a slightly prolonged response to Suxamethonium, and a very tiny subgroup of about 3 in 10,000, so 1 in 3,000, and getting rarer, might get stuck paralysed for a couple of hours. Now you could give everyone Suxamethonium, intubate them, get them maintained, and then check a train of 4 at 5 minutes and 10 minutes to check for resolution of your Suxamethonium. By doing this you might catch a few atypicals, but no one really tends to do this. The treatment for sux apnea can be 2 different things. 1, a calculated dose of time whilst keeping the patient asleep and not wheeling them through the hospital without any sedation on board, wondering if they've had a stroke, and putting them through a CT scanner. So keep your patients asleep. Do a train of 4. If they remain paralysed, you know that something's amiss. Now you could very much go and plonk them on intensive care. Your other treatment option of choice is giving them fresh frozen plasma. You can give them someone else's plasma cholinesterase, and it'll mop up the Suxamethonium and they'll stop being paralysed, and you can wake them up and it's all tickety-boo. So you can either wait or give them FFP. If you wait, they will eventually pee the Suxamethonium out. Either way, you're going to send them to clinical genetics and refer them for testing afterwards. Don't forget it causes anaphylaxis. It certainly causes bronchospasm, and you might think you intubated the esophagus when you didn't. And that masseter can sometimes be a precursor of the patient developing MH, and it also makes it quite hard to intubate the patient if they've got a nice tight masseter muscle. Anyway, I'm going to give you 4 takeaway points for Suxamethonium. Suxamethonium is an emergency drug, and knowing your doses of it and where your Suxamethonium is in relation to you is smart moves. It can be used when you're unable to manage an airway in a gas induction with no IV access, but the onset time of 3 to 4 minutes is going to be a very sweaty 3 to 4 minutes if you're having airway troubles in a gas induction with no IV access. And it can be used to manage laryngospasm in that peri-extubation period. It is useful for interventions that are brief but require a tube if there are patient or surgical factors that necessitate that. It is still used as the drug of choice in emergency obstetric intubations and general anaesthesia, at least in the places where I have trained and worked. The side effect profile is a great topic to discuss in the Viva, as there are multiple interesting pharmacological and physiological avenues to explore and go down several rabbit holes thereof. The last point I'm going to say is the dose of Suxamethonium is not just 100 milligrams for everyone. 1.5 milligrams per kilo in an adult is probably where you want to be, even if that means cracking a second ampule open. I say this having perhaps inadvertently underdosed a patient at some point in my training and finding it quite challenging. I hadn't fully appreciated at that point in time the rate of metabolism of Suxamethonium before it gets to where it needs to go, i.e. your muscles. So I now give 1.5 milligrams per kilo to anyone who I am giving Suxamethonium to. Now, I can't tell you that I use it very much, but that's my 2 cents. So you've been listening to Gas, Gas, Gas. My name was James. Thank you very much. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.